So thank you so much for inviting me this morning to join you. And my topic is Beyond Early Childhood Caries. What is LCC? And so I'm speaking to you from the North Carolina in the United States. It's early in the morning here. And thankfully, thankfully for us in North Carolina, we were impacted very little by the most recent hurricane, but we have to think about our friends in Florida and Georgia who were severely impacted by this last hurricane that we had. What's interesting about my career is I'm both academic and also have a large private practice associated with Duke University. And my PhD is in epidemiology, so I'm one of the things that I'm constantly looking at are patterns. And so if you just look at the classic early childhood presentation, typically is the 4 upper incisors and with or without involving the first primary molars, as Professor Muth was just recently talking about. But if you look at the definition of early childhood caries, and not the severe, but the early childhood caries, it extends all the way to the age of 6. So we're ignoring in the primary dentition the ages of 6 to 12, and the caries potential lasts from the eruption at age 6 months of the incisors all the way to full exfoliation at typically 12 years of age. So, the question I pose to you is, what is the most common surface that we restore in the primary dentition between the ages of 4 and 12? So ponder that thought as I go through this talk. So caries not involving the maxillary anteriors is this pattern that we see over and over in private practice. The typical 4 to 5-year-old first bite wings has 8 interproximal lesions involving the first primary molars. And here's another child, Teddy, age almost 5, and you can see that he has varying levels of caries, acidas, the way from 1 to 6, involving the interproximal surface of the primary molars. And then Isaiah is presenting the same thing. His first bite wings were obtained at age 6 years, 8 months. And we nickname this pattern in the South United States the 8 chewing cavities, because these are the teeth that you chew with, and then you're seeing the lesions interproximally. And so the risk period for interproximal disease typically is between age 4 and 12. And the critical event that's predisposing the primary molars to this caries pattern is the space closure of the primary molars, which on average happens at age 4, with the effect of the emergence of the 6-year molars. So prior to that, food particles, liquids could easily flow through that space created. So a child that's got more diastemas obviously has a less caries risk than a child who's very crowded. And so certainly with the pandemic, we saw in the United States a significant increase in dental caries in the what we call the 8 chewing cavities. And in fact, we have a different study looking at in the state of North Carolina at our Medicaid data, and what that treatment data showed that our treatment cost dollars for children is far exceeding with interproximal decay in the molars than the classic ECC pattern. So none of the children that I showed you, and then we have a large population of children that really the main cavities that they're presenting with are the 8 interproximal, and they did not have any of the previous classic ECC, though certainly as a wise clinician, you know that can happen, and that would be one of the worst case scenarios for a child to have ECC as well as this later pattern. So what we proposed in our research project, which I'll share some of the data with you, is that late childhood caries, LCC, is occurring between 4 and 12, between the interproximal surface of the primary molar, and severe LCC would be involving the more anterior contact, the mesial of the first primary molar and the distal of the primary canines. And if you were to look at those 2 different patterns of mouth, the severe LCC child is severely crowded and there's no developmental spaces. So I'm not quite sure that sounds coming
sounds
from
coming from
Waking with Dr. Professor Buzz Talk is that looking at children early and pediatricians looking early is one of the risk factors that we're studying in our grant with Professor Margarita Fontana is crowding. And if you see the primary dentition with no interdental spacing, that's putting that child at a much greater risk of interproximal disease later, which is something a pediatrician or a nurse or a general dentist could easily identify as another risk factor to get that child into a dental home as quickly as possible. And then the question has to be asked is, are there different caries risk assessments that need to happen comparing ECC to LCC? And are there different dietary factors that we need to emphasize? For instance, would liquids be more important a risk factor in ECC, like juice in the bottle, soda in the bottle, tea in the bottle with sugar, versus in LCC, it's more dominated by what you're masticating versus what you're drinking, because in the interproximal space, it's where you're chewing food. So that's moving you toward talking about dry cereal, sticky foods, gummies, gummy vitamins, the sticky candies, if you will. And here's just a picture of the fruit snacks, which are quite popular, unfortunately, in the United States, as well as the gummies. And certainly since the pandemic, we've had a huge uptick in the United States in consumption of vitamins, with the supposition that parents believe if their child's eating the vitamins, then they won't get COVID. And so these have a 3 to 5 gram sugar content, which is an increased caries risk. So, an interesting question also to pose is is LCC more predictive of caries in the permanent dentition, or is it LCC? And we do know from the classic Lee and Wang study back in 2002 that children having caries in their primary teeth are 3 times more likely to caries in the permanent teeth. But the question is, can we dive deeper into that question and see if there's a pattern that's more predictable? And so, the ultimate disaster in a pediatric dentist's hand is to start to see the breakdown of the interproximal surface of a permanent 6-year molar. I mean, we have sealants that can protect the occlusal, but we hate seeing this. And so can we prevent it? So as an epidemiologist, we are always looking at disease misclassification. And as Chin described, the misclassification of caries disease patterns can affect our understanding of disease experience, risk, and affect implementation of appropriate preventive strategies. So we propose, Professor Fontana and myself propose, that our definition of ECC overlaps LCC and prevents us from really looking at preventive strategies more correctly. So this is our large prospective cohort study. We're based at 3 sites. I'm the PI at the Duke University site. We have children being followed at Indiana, Iowa, and Duke University. And we've now been funded. We just recently got funded for 5 more years. So we will take this cohort of 1,300 children from age 1 all the way up through exfoliation of the primary dentition through 15. And what's also interesting, we were one of the first studies funded by the NIH we are allowed to take bite wing radiographs. And you can see at the bottom of this slide, what I want to share with you is just our visit dates to date, visit 1, age 1, all the way up to visit 6. And starting at visit 4, age 6.5, we're able to obtain bite wing radiographs on these children. So we're adding significantly beyond NHANES data, really what is happening in terms of caries experience for this population. We're also collecting genome data, microbiome data, which the wonderful group in the Netherlands at ACTA is analyzing our microbiome data. But here's the life cycle of the primary dentition that, from the Bangkok Convention, we know severe ECC is up to age 2.5. ECC has been defined up to age 6. I'm marking age 4, the classic time of closure of the molar contacts. We've ignored in our profession what's happening from age 6 to 12, which is the typical exfoliation of the last primary tooth. And this is something that Dr. Fontana and I published in Pediatric Dentistry. And so we took my private practice, and looked at 25 years of the Caries distribution pattern. And what we found was that 70% of the children, the pattern was LCC, 25% was ECC, and 5% was the primary second molar hypoplasia pattern. So we hypothesized for our grant that there are 3 patterns, that early childhood caries should be age 1 to 4 with the physiologic closure of the contact, be the beginning point of LCC, late childhood caries. And then there is that 3rd pattern that we can't ignore, which is just the presentation of primary second molar hyperplasia, which can only start when you see it after these teeth erupt, which is typically 2.5. So here's the dominant global caries patterns that we propose for the primary dentition, that we change the time frame of ECC. And we've certainly gotten a lot of pushback about our concept, because there is so much data and research about ECC, but I think we need to move the dial forward and try to be innovative and really look and say, are we missing the opportunity to dive into looking more closely at LCC? And then I drew the circle for the hypoplastic second primary molars would be happening. We would start to diagnose that after their eruption, which would be after 2.5. So I wanted to share with you some of our data to just give you a visualization. So just looking at our 1,300 children at age 1, if you just want to look at the red numbers, you can see that the caries distribution is predominantly in the maxillary incisors, 0% in all the other teeth at age 1. Moved to 2.5, 7% of our children have cavitated lesions. We use the ICDOS system. You can start to see we're picking up caries in all 4 of the incisors, as well as the first primary molars, which you might predict. And then we look at age 4, and you're seeing 24% of our children have cavitated lesions, and we're starting to pick up caries in the second primary molar. Jump to age 6.5, and of course, in any prospective cohort study, you're going to have attrition, and then throw on top of that a pandemic, which added to our attrition. But we were an unusual NIH grant as well, that all 3 institutions allowed us to still keep examining these children during the pandemic, because we didn't use aerosol. So look at age 6.5. We're now switching the distribution of the caries pattern to be predominantly in the primary molars. And then let's just compare age 2.5 to 8. And so you can see that the distribution for ECC is predominantly those maxillary incisors in the first primary molars, and you shift age 8, the predominant pattern is in the primary molars that are cavitated. Let's take a deeper dive and just look at our surface data. And you don't have to read all the numbers, just look, I colored it so it makes it easy for you. So at the top, you'll see in blue age 1, 2.5, 4, 6.5, and 8. So in yellow, you're seeing the caries start to wane by age 4 in the primary incisors. And then look at the green, where we're starting to pick up caries in the in the primary molars, picking up a few as early as 2.5, which you can see those are those occlusals associated with ECC. And then you're starting to pick up at age 4 the interproximal lesions, and definitely by 6.5 you've got mesial and distals, and by age 8 the interproximal. And then picking up at 8, we're starting to pick up caries in the occlusal of those permanent molars, which is in purple. And so the key trajectory findings that we were finding is that primary anterior caries in our population really waned by 4 years of age. And then you can see the distribution at visit 1 and 2, that we went from 0.2% caries to 4.8, and then only 5% had caries beyond the maxillary incisors. So let's look at just specifically the posterior interproximal surface data, age 2.5, 4, 6.5, and 8, and just focus on the red. And you can see that we did pick up some early 2.5, but the large majority are definitely picking up 4 and 6.5 and 8, where we're picking up those mesial and distal surfaces of those teeth. And you can, if you look a little closer, what you can see is it's the distal surface of the first primary molar is the first surface to be affected. And then with time, we're picking up the mesial surface of the second primary molar. So our key trajectory findings was that 67% of our children were caries free at visits 1, 2, 3, but at 4, we're starting to get visit 4, 6.5, getting caries in the primary molar. Almost 50% of the children were caries free all the way through visit 4, but then developed caries at age 8. And 82.5% of the children with any caries on the primary molars at visit 4 went on to develop more caries lesions by visit 5. So once they've got it, they're going on to develop even more. So the predominant pattern starting at age 4 through age 8 in our study is the posterior molar caries experience. And then looking at the trajectory, which has been looked by many other scientists, that if you look at the distal surface of the first premolar at visit 3, 42% went on had caries on the mesial surface of the second primary molar. Then 73% at visit 4 had the next surface affected, and by visit 5, 81% of the children at visit 3 that had the distal of the first primary molar affected, their mesial surface was affected 81% of the time. And then you can see the same trajectory is happening at visit 4 and at visit 5, that if you look at visit 5, if they had caries on the distal of those first primary molars, 74% went on to develop caries on the mesial surface. And an interesting question to ask looking forward in our data is what we want to know is, will the same pattern repeat itself with the caries pattern on the distal of the second primary molar? Will that be the predictor of caries on the mesial surface of the permanent molar, which is something we definitely do not want to see. So stay tuned as we collect that data for you. So these are the predominant patterns that we propose. I did want to just briefly highlight our data on the hypoplastic second primary molars. So here was our data, DMF1 and DMF3, showing you how our data is good, meaning that we shouldn't be seeing any primary second molar hypoplasia at visit 1, and we don't. We're starting to pick up a little bit at visit 2, which is 2.5, but definitely by visit 3, we're picking up caries only, and that's a caries experience. It's only on the beginning, on the occlusal, related to the defects of the second primary molars. And you can see that here's the distribution. We had a few at visit 2, but predominantly it's at visit 3, and this is a picture of one of our patients. And the reason why we're collecting this data is we want to look at the trajectory of this pattern of how it's predictive of MIH in the permanent dentition, is that this pattern would go on, that we will see this in the permanent dentition. So our future planning is to continue to follow this cohort and refine the classification of dental caries in the primary dentition from eruption to exfoliation, and really look at the trajectories of these different patterns and try to identify the ones that are most likely to predict caries in the permanent dentition. And we're planning to look at the risk factor patterns. And we do have, we just finished and then ORCA presenting most recently the differences in the dietary exposure risk factors between ECC and LCC, and it is clustering when we do factor analysis between ECC is more a liquid-based exposure, and LCC is more what the risk of what you're masticating. So it changes the conversation and actually adds more to the discussion when you're doing dietary analysis with children and parents, as it's not just talking about what you're drinking, what's in the bottle, what's in the sippy cup, but taking a deeper dive into what they're masticating. I do want to recognize our amazing research team around the world that's helping us. As you can see, we've got the biomarker team and then the temperament team looking at the temperament of these children from New Zealand and Canada, as well as looking at some of the cost predictions from our data. So I wanted to just leave up our slide, and hopefully I will have many of you embrace what Dr. Fontana and I think is probably where we need to shift our research and conversation. I know it might be seismic activity to be able to redefine ECC one more time, but I think it's worthy, and also looking at the cost impact to our individual countries of involving LCC. So I wanted to thank Dr. Matthew. Thank you so much for inviting me this morning to share with you our concept of late childhood caries. And I'm more than happy to entertain any questions. Thank you.